Good morning. I'd like to thank the organizers for having me. I'm a clinical psychologist. I'm also a health services researcher at UCSF Benioff Children's Hospital in Oakland. And I appreciate the talks that have come before me yesterday and today. What I'm going to be doing is talking with you about mental health issues across the life course in sickle cell disease. But while they're pulling up my slides, I'll just say that my objectives are going to be to talk with you about major mental health issues that can arise across the life course in sickle cell disease, to talk with you about risk and protective factors for those issues that can arise, and to talk with you about some promising therapies that are under study or should be studied. So the individual with sickle cell disease, as was mentioned yesterday and today, shouldn't be thought about as just a complication or even as just an individual, but rather you have to really think about people with sickle cell disease within the context of their families, within the context of informal and spiritual supports, their culture, community, as well as formal supports. And again, later this afternoon, talking about public health, you have this range of contexts within which people with sickle cell disease live. And I use the term life course, which is a little bit different than lifespan in the sense that it really refers to that there are key periods in people's development where trauma or adverse experiences can actually impact later mental health or the course of their life. So that's why I use this term life course. And it has been shown that health trajectories can really be affected during critical and sensitive periods. And again, that the broader community environment is really affects the ability to be healthy. But before I start talking about my slides and my presentation, I wanted to bring the words of an individual with sickle cell disease who died about 2 years ago. His name is Albert Johnson, but he's also known as Prodigy, and he was part of a hip-hop duo, Mobb Deep, and he died related to sickle cell complications about 2 years ago. So I found his words really compelling, and I won't read them, but I've transcribed from an New York City Realness podcast some of the things that he said about his experience living with sickle cell disease. He really talked a lot about the pain and about the fact that he used his music to overcome the challenges that were brought to his life because of the pain. Now, he was a person who lived in a very well-to-do family, a family of musicians. His grandmother had a dance studio in New York City. So his issue really, he was very articulate about really the impact of the pain on his life, and that it made him angry inside, it made him mistrusting, and that he had to get his aggressiveness out somehow. But I just want you to think about what that experience of pain might be and what other people who don't have that coping mechanism might go through when they don't have that ability to let their aggressiveness out in the way that he did in his music. The other thing I want to point out, in this podcast, they interviewed his family members. And an extended family member talked about how he became very rude and short and just didn't enjoy life around 12 anymore. And that is classic depressive symptoms for a young person. They don't necessarily look mopey and sad, but they can become quite irritable. And in fact, at the age of 12, he tried to commit suicide. And again, he really points to the pain that was the issue for him. And his mother found him trying to slit his wrists. She did get him into therapy, and he also was a good spokesperson for the importance of therapy later in his life. But it's key to know that the experience of sickle cell disease, the experience of the pain that's a part of that disease, can lead to serious psychological problems. So what's the prevalence of mental health disorders? The World Health Organization puts forward some lifetime prevalence figures worldwide. So for anxiety, about 2.5 to 7%. depression 3 to 6%, and attention deficit hyperactive disorder about 7%. In the sickle cell population, there's a big range of the estimate of prevalence because of inconsistency in how depressive disorders and major depression or anxiety is measured. But you can see that for anxiety that you have a much bigger spread and a higher number as far as the estimated prevalence. Same thing for depression, as well as hyperactive disorder. So some of the challenges that can arise for individuals and that can lead or contribute to some of these mental health symptoms include in infancy, and so we're looking at this from a developmental standpoint. So in infancy, that the family is the key to a child's development. And sometimes parents may feel guilty or helpless or depressed themselves. A child's temperament that doesn't match their family's temperament can cause some challenges. And then as children move into school, their inability or ability to attend school on a regular basis, perform well academically, and maintain peer relationships can cause or be protective against mental health issues. In adolescence, transition is huge, and experience of discrimination and stigma do start to occur for adolescents and young adults, and these can contribute to mental health symptoms, as I'll talk about a little bit later. In young adults, the illness effects become cumulative. It's not just physical, but the cumulative effects of dealing with all of these complications can contribute to depression and anxiety. If a person feels that they're dependent on their family longer than their peers, or they have trouble coping with stress or financial employment challenges, again, this can contribute to mental health challenges. And now we do have mature adults and seniors who living with pain, fatigue, dialysis, heart disease, and so on, can really cause and contribute to mental health symptoms. But again, pain is a key feature in sickle cell disease and is key in some of these symptoms that I'm going to talk about in a moment. The uniqueness of sickle cell pain, its unpredictability, uncertainty, and early onset is particularly challenging, and pain is not benign. It creates an autonomic stress response. In the stress response system, there can be changes in functional status, downtime. Emotional reactions create a vicious cycle. So as one experiences more pain, one can become anxious and depressed, and then as one is anxious and depressed, one can experience more pain. What's the meaning of pain that the patient makes? If you think, I can get over this, I'll be okay, as opposed to, this means I'm dying, my life is terrible, then the meaning that a person makes of the pain can influence how strongly or intensely they feel the pain. And again, family responses and family coping are key. This tip of the iceberg phenomena that many of you seen from Wally Smith is not just about that what you see in your office or clinic is the tip of the iceberg of pain, but also what's the impact of the pain. So correlates of frequent pain include negative self-concept, again, this cycle of anxiety and depression, negative body image, poor school performance, and so on. So what you see in front of you in terms of pain, again, is just the tip of the iceberg of what people are experiencing and the impact on their lives. Stigma and bias does occur for people with sickle cell disease. This information is about stigma within the healthcare system in the US, but there also are other sources of stigma within the community that people can experience when they have sickle cell disease. But in the US, when people experience stigma related to bias, in racial bias, they reported greater pain intensity and a greater pain burden. Also lower quality of life. Hesitancy in seeking treatment, which creates another sort of cycle in terms of achieving the best outcomes. And then loneliness, lower health-related quality of life, less pain reduction, anger, fatalism, and these can come when providers view the person as drug dependent. Stress not just from pain, but the stress of dealing with sickle cell disease, the illness tasks, making your way to the hospital on a regular basis, taking medications and so on. Good psychological adjustment can be related to lower levels of perceived stress. And in one study, the question was, does stress come first or pain? And it was found that pain actually was predictive of increased stress. Although, again, that really is a cycle. So that pain, stress, and mood can create a cycle within sickle cell disease, so that, again, individuals have limitations in their activities, higher healthcare utilization, or less if they're avoiding utilization. And these issues are particularly pronounced as people move into adolescence and young adulthood. But a protective factor against all of this is what's called self-efficacy. And that is the belief that one is able to complete the tasks and reach their goals. And so enhanced self-efficacy in sickle cell disease has been associated with fewer psychological and physical symptoms. And I'll talk later about how to build self-efficacy. You heard a talk this morning about neuropsychological symptoms in sickle cell disease, and this has been touched on. But another interesting thing to think about is stroke and silent infarcts actually affect coping, and in fact can be associated with depression in a very specific kind of way. So in this very recent study, they looked at working memory specifically and how it might be related to depression with coping, such as active coping, distraction, what's called cognitive restructuring, where you change the sensation of the pain in your mind or you think differently about it. How are these all related? And what these authors found, and this is from Michael DeMond's group, is that there was a direct effect of a neurocognitive challenge on depression. So people with lower working memory had more depressive symptoms, but then it also was mediated through the coping mechanisms that the person either had access to or not because of silent cerebral infarcts and stroke. They also wondered if verbal comprehension would have a direct effect on depression or be mediated through how verbal comprehension would affect coping. And in this case, they found that there wasn't a direct effect, but there was a mediated effect where the verbal comprehension affected how the person coped, and then they had more depression. Health-related quality of life is impacted by mood disorders, and in every way, so social functioning, emotional role functioning, and mental health, of course. And this is both for adults and children, so that as well, when people ask what is a bigger contributor to the lower health-related quality of life as well as mood disorder, pain has been shown to be a major contributor. But environmental stress is a contributor to low health-related quality of life, and depression is a strong predictor of those low scores of health-related quality of life. So that is related somewhat to social determinants of health. And what are these? Well, these are poverty, poor schools, unemployment, and in early studies it was suggested that poverty and in illness would be cumulative, those negative effects would be cumulative in sickle cell disease, and that has been borne out over the years, so that there's a higher prevalence of poor psychological adjustment when people live in poverty, as well as academic underachievement and increased utilization for acute events. Families can either be stressful or helpful. So we all know this. So when they are stressful, it's because they're conflictual. Parents or family members may be too controlling and unable to let go of the child. They may not be as supportive as they could be, limited in terms of providing physical and emotional resources. And again, the parent's own anxiety and depression and coping influences the child's coping and even the adults. But great adaptive functioning can be associated with family cohesion, positive communication, a responsive family context, and low levels of conflict. Social support goes beyond the family. There are social support groups. There are lots of advocates here at this meeting, and it's been shown that social support is very helpful. In this day and age, social media is very helpful. There are support groups that have thousands and thousands of members related to sickle cell issues. And there's also a recent focus on community health workers, who are people from your community, whether they have sickle cell disease or not, but they are usually from an individual's community, and they can really help assist with developing health efficacy, adherence, and providing social support. Culture, like family, again, can either increase stress or enhance coping. So there are cultural beliefs or health beliefs related to acceptance of the person with sickle cell disease, ideas that this disease came from the mother as opposed to from both parents, calling it, quote, bad blood, or passively relying on a miracle to change things rather than being active in coping. All of these cultural variations could increase stress, whereas there are cultural beliefs that can enhance coping, beliefs that every child is a gift. Children with sickle cell disease are smarter because they are less athletic. Families who rally behind their families or their family member, and then prayer, faith in God, and so on. I just wanted to, I know this may not be easy to read, but there are recommendations for mental health screening. And I think that this topic of this part of the conference is related to underappreciated issues. And I think that regular screening of depression and anxiety, despite the high prevalence, doesn't happen as often as it really should. And so these recommendations come from the U.S. Preventive Services Task Force, and they recommend that adolescents be screened at age 12, that there's strong evidence for that, as well as adults. There isn't as strong evidence for children. But look at some of the risk factors, again, for depression: low SES, poor academic performance, family conflict, chronic illness, which sickle cell disease is, and similar to adults. So in other words, these are the very people that we should be screening on a very regular basis, and yet are not. However, the task force does also suggest that you need adequate systems in place to ensure that the diagnosis is accurate and that there's effective treatment and appropriate follow-up. And I'm sure that, again, in many of your settings, that isn't actually the case. So if we move into what are some interventions to improve mental health functioning, this one type of therapy is called cognitive behavioral therapy. And what it does is look at the relationship between thoughts, feelings, and behaviors, and really helps people to change any one of these areas to influence the others. So if you have a lot of negative thinking, again, that can extend into negative emotions. But if you have positive thinking, or realistic thinking, I would say, then that can enhance, again, your coping. And so I just wanted to go very quickly over showing you that there have been studies of cognitive behavioral interventions in sickle cell disease, but these have been small studies, single-site studies. And again, in a minute, I'll be able to show you that there are a lot more studies going on, but there even need to be more, and there need to be more studies that are across sites so that we can have bigger sample sizes. But there is evidence that patient and family education is helpful, although some group therapy didn't show a significant reduction in depressive symptoms, but disease knowledge does improve, and that can be helpful. Further, as I mentioned, support groups. There hasn't been recent study of support groups, but when people attended support groups for a long time and were satisfied with the group, that could be helpful. Oh, sorry. So this is just, don't need to go through the details of this, but these are current studies, and you can see that many of them are actually across sites, and look at things like coping, teaching cognitive behavioral therapy on an internet version, patient navigators used with about 400 patients. So again, there are active trials, and I went through those slides fast because I'm not understanding how to use this after all of my practice. To just, again, to let you know that there are studies that are ongoing, but there need to be more multi-site studies. One thing I wanted to point out is something called the collaborative care model. Psychiatrists working with sickle cell disease can be as rare as adult hematologists taking care of people with sickle cell disease. So in the collaborative care model, the psychiatrist consults with social worker or psychologist and the healthcare team and doesn't have to see the patients in terms of medication monitoring. And then other types of therapies, trauma-informed care, acceptance and commitment therapy, mindfulness-based therapy, all of these are very helpful in other conditions, but they have not been studied yet in sickle cell disease, and they really need to be. So in conclusion, I just want to say that there are still a small number of trials evaluating interventions to target enhanced coping and self-management. The most promising are family education and cognitive behavior therapy, but they still haven't met the criteria for well-established interventions. There's too much heterogeneity in methods and measurement, and that really does need to be improved, as well as these small sample size. So we're really ripe to rigorously test diverse interventions that can promote positive coping. So all of us need to think about evaluating targeted, problem-focused treatments to reduce symptoms and prevent the ongoing escalation of distress, because that can be a marker for later problems in terms of mental health issues. And there may even be critical or sensitive periods that we just don't know about yet. Community collaborations are important, as well as consortia. So thank you. Oh, there's one.
Thank you. Question, Katerina.
Do I need the microphone?
I don't think you do.
So listen, thank you so much for this presentation. I wanted to ask you a question, and I don't know if there is an answer, but during my time in New York, I noticed that we have a large percentage of Hispanic population. And when you talk about cultural sensitivity and difference in coping, in my experience, and of course I don't have any data, but I really would like to get data, I noticed a completely different coping mechanism, actually the lack of coping. An absolute lack of coping from patients that are Hispanics. And I also noticed that many of my patients are the first in their family to have sickle cell disease, and they feel very isolated and frankly lost. And even though I haven't studied this, I'm just, maybe somebody else wants to study, but I find a huge difference in their coping. I can tell you, my impression is that the Hispanics, they're just, they give up. You know, I find sometimes other patient populations are kind of fighting, they're angry. They are just resigned to just suffer, and it really breaks my heart to see this happening.
Yeah, we have a large Hispanic population in California as well with sickle cell disease. And I think the real issue is lack of education about the fact that the disease does have a higher prevalence in that particular population in the US. And so that, yes, people are often isolated because there haven't been other people that they know, and people just have a lack of knowledge about it. And a personal experience was a family that came into our clinic, a young boy who was brought in by his two grandmothers. And when we handed them materials about sickle cell disease in Spanish, they just started crying because they felt so isolated and like there wasn't information for them. And I think that's a lesson for all of us around the world, that there needs to be information for everyone so people don't have, isolation is a huge problem it's a huge problem related to coping positively. So we do need to decrease that.
Thank you. I think we're going to have to move on. We're behind time. We can take questions at the end for everyone. So we'll next move to orthopedics in sickle cell disease, and Marcus Banks from Guy's and St. Thomas will take us through that journey. Thanks, Marcus.
Thanks, John. Thanks, Marsha. I really enjoyed your talk. It resonated a lot with me because I only really see sickle cell patients that actually have pain. I work in central London. That's my hospital. I know, and we're going to just advance. I'm going to show you another picture of my hospital. There we go, that's my hospital. It's a fine piece of brutalist architecture, just next to London Bridge Station. Anyway, I'm going to talk to you about orthopedics in sickle cell disease. I'm not really going to talk about infection because you guys deal with that much more often than I do. I'm going to talk to you about avascular necrosis and how it develops. I'm going to talk about the distinction between the femoral head that's collapsed and one that hasn't collapsed, and how that's a key distinction in the treatment of avascular necrosis. I'm going to talk to you about total hip replacement in sickle cell disease. This is a really good news story. This is a safe, predictable operation now, as safe and predictable almost as in the non-sickle cell community. I'm going to talk briefly about alternative treatments for avascular necrosis in other parts of the body, and alternative causes of hip pain. Now, this is almost the same slide as Marsha had with showing the locations of pain in sickle cell patients. Avascular necrosis affects the hip and the shoulder primarily. They're the most important sources, but it also affects the vertebrae in the spine, the ankles and the knees occasionally. These are all characterized by end organ disease. So if you lose your blood supply to those areas, then there's no other blood supply to take over, and so death of the bone ensues. If you've got death of the bone, then it loses its structural integrity. You get death of the marrow. Now, if you've got dead bone, there's three consequences, really. Firstly, it's very painful. Yeah, dead bone is painful. We're all familiar with that. The other thing is it loses its structural integrity, and therefore you get collapse of the bone. And this is basically a disaster. And critically, you also get loss of adhesion between the cartilage and the underlying bone. And this is a thing that's really, really underappreciated, because that, I'm afraid, spells a death knell for a hip. If you do have loss of adhesion, the cartilage becomes really quite wrinkly, and that diagram just shows just how close the association is between the cartilage and the underlying bone. And if you actually lose that adhesion, you literally get a space underneath the cartilage between the cartilage and the dead bone, and that has a very poor prognosis. This little video, just the pink area is the avascular segment. This is a femoral head that's been removed. And the avascular segment, you can see it's all wrinkly and the cartilage is coming off. So even though the cartilage is still there, it's not actually particularly effective, and it's highly prone to damage because it's all rough and it just gets caught all the time. And if you get continued collapse, continued cartilage damage, you get end-stage damage of the hip. It's even more painful. You start to lose movement, you get fixed deformities, the leg becomes shorter, and the pain levels go up exponentially. Avascular necrosis is very easy to see on MRI scans. We're forever getting MRI scans of patients with hip pain looking for avascular necrosis. It's not the only cause of hip pain in patients with sickle cell disease. This is a very characteristic appearance. But unfortunately, if you even just write the word sickle cell disease on an MRI request form, that you'll get avascular necrosis being reported. So I would get quite familiar with looking at these yourselves so that you're not misled by less experienced radiologists. Now, identifying collapse of a femoral head is absolutely critical. A femoral head that's not collapsed is basically when it's all still nice and round. So go into your geometry sets, draw a circle around it. On PAC systems, you can actually superimpose circles on pictures now. So that's an uncollapsed femoral head. Perhaps unsurprisingly, this is a collapsed femoral head because the avascular segment is no longer congruent with the circle. So I think that's fairly straightforward, I think. This young lady has avascular necrosis of her right hip. And sort of looking at from the back of the room, you may think, oh, that's not collapsed, that's all look fine. There's a big segment affected, but it still looks pretty round. If you look at it sort of in greater detail, in fact, nothing is really further from the truth. That's one circle, and then the pink circle is the circle superimposed on the avascular segment, and they're not congruent. And those, that's collapsed disease. You can also see it on the side view X-ray. No one takes these anymore. This is the crescent sign, the classic crescent sign. But again, you can see that the collapsed segment being seen through the uncollapsed segment. And of course, this is what happens a few months later. Luckily, that was just before she had a hip replacement. So what are the factors that affect treatment of avascular necrosis? Well, they can conveniently be summarized as SCD. So symptoms. A patient has to have significant pain to warrant any kind of treatment. Just because you see it on an MRI, asymptomatic disease does not need treating as far as I'm concerned. There may be a place for medical treatments that are as yet unproven at the moment, but that's potentially the place there. You need to look at whether there's collapse, and collapse is a binary decision. Okay, again, you'll see on your MRI reports from your radiologist, partial collapse. If there's partial collapse, it's collapse. I liken it to the presence of your keys to get into your house in the evening. You've either got your keys or you don't have your keys. It's a binary decision, okay? Is it collapsed? Is it not collapsed? And then the final thing, I was looking for something that began with D, degree of involvement of the femoral head, yeah? So if anyone comes up with anything better, answers on a postcard, please. So this is the treatment algorithm for avascular necrosis, and there's the uncollapsed pathway and the collapsed pathway, but unfortunately all of those seem to lead to THA, which is total hip arthroplasty. So as we move forward, unfortunately all roads are leading to Rome. And we're far more likely to do hip replacements for avascular necrosis for everyone, not just in sickle cell disease, for a number of reasons. And firstly, total hip replacements are excellent. And the other thing is that other treatments for avascular necrosis just don't seem to work very well, or they'll work for a bit and then they fail. The advantages of hip replacements is one-stop shopping. You have your hip replacement and basically you're cured. And I think that's a key thing, that we mustn't put our patients through surgical procedures that just aren't going to work. The other thing is that hip replacements provide very comprehensive pain relief. Patients get back to normal. Whereas if you do a bit of core decompression, a bit of fiddling around, yeah, it may help a bit, but they're still taking painkillers, they're still limping. So it provides really high quality pain relief and a really, really good hip. It's become the surgical procedure of choice in sickle cell disease in my hands. And also you must plant the seed of this early in patients' minds, because there'll be a fair amount of denial or just not wanting to have surgery because of the reputation of surgery in sickle cell disease. You need to sort of get them on message early, so they've got plenty of time to think about it and organize their lives. When do we do hip replacement surgery? Well, we do it for collapsed disease. That's of any kind, of any size, with significant symptoms. They tend to get pain in the groin. Night pain makes their life miserable. They'll be limping, and basically daily life becomes a grind. And these are young patients. They're in education. They're parents. They need to get to work, and they need to get on with things. So this kind of thing drives me mad. This is an obsolete concept in modern orthopedic surgery. You're never too young for a hip replacement, and total hip replacements in young people, as there are all these sort of false myths and attitudes around it, that it's some dangerous operation in sickle cell disease, which it isn't. Hip replacements are only for old people. Well, yes, more old people have hip replacements than younger people, but I can tell you quite a lot of young people have them too. That only low levels of activity are possible. Well, that's just not true. Loads of my patients, well, not sickle cell patients particularly, but go skiing, play tennis, go charging around, they run, they do triathlons, do all sorts of things. Now, this is a key thing as well, that implants only last 10 years, following which there's some disaster or catastrophe that will ensue. Basically, modern hip replacements last at least 2 decades with the technology that we've got at the moment. And the longer we look at them, I think the better they'll perform. And this final point is that a patient who is miserable, struggling with daily life, that this situation is somehow acceptable. And that, an orthopedic surgeon will say, you're too young for a hip replacement, and yet you've got a crippled patient in front of you for whom you have a perfectly good treatment. And this is absolutely just not acceptable anymore. Clearly, in sickle cell disease, the results of hip replacement have been very poor traditionally due to a number of issues that we've now largely solved. And one of the things that really helps is having a multidisciplinary team looking after sickle cell disease. This is myself with Joe Howard, who's our sickle cell doctor, and Neil, the long-serving sickle cell nurse. He's been, and we all Neil and I sort of started together around the turn of the century. So he tells me what to do, and that's always been that dynamic. Now, in order to do hip replacement safely in sickle cell disease, exchange blood transfusion basically normalizes the whole situation. If you can get their sickle percentage down to 50%, Dr. Howard spoils me and drops it down to 30%, then really these are routine procedures, and they come in and leave hospital just like the non-sickle patients. Now, not everyone can have a blood transfusion in sickle cell disease. They may be theological or immunological reasons, and sure, those cases are a little bit more hairy. We still do them, but as a result, we never really ever give blood during a total hip replacement. A total hip replacement, doesn't need blood during surgery. We use cell savers as well because we're salvaging the exchange blood. So that seems to work very well. So cell savers work well in an exchange patient. But also, they just lose very little blood. And of course, the other people that would need blood, we haven't been able to exchange anyway because they're not suitable for it. Infection, we seem to have solved that with a couple of antibiotics, one for gram-positives, one for gram-negatives, just try and keep it nice and straightforward for the anaesthetists because they get very confused. Unlike orthopedic surgeons, we understand everything, particularly antibiotics. We used to put in ciprofloxacin, but we've got rid of that because it didn't really seem to make any difference. Uncemented fixation vastly superior. So cemented cups, absolutely useless in sickle cell disease and absolutely should not be used. That's like sort of treating things with leeches or something. It just doesn't work really. Some uncemented stems work very well. But occasionally there's a place for cemented ones. But the key thing is the bearing, the moving parts. And this sort of little cartoon just shows hip replacement articulations, sort of where simulator studies these are, and about how much debris is produced from these. Now, on the far right is a traditional metal on poly hip replacement, and these are the ones that wear out in 15 years. But I use the thing on the left, which is ceramic on ceramic, and it doesn't really wear at all. The middle one, CE, ceramic on XPE, is highly cross-linked polyethylene. That's pretty good. It's cheaper. It's pretty good. So I think that's acceptable. But I think anything other than those two bearings in anyone under 60 years old is just not really acceptable. The benefit of ceramic bearings is borne out in the literature. You can look that article up in yourself. So in general terms, you're never too young for a hip replacement anymore. And I think that's the key thing. And this is just for everyone, not just for sickle cell patients. If you've got patients limping in with who knows what's wrong with them, modern hip replacements work really well. Now, at Guy's, we've been doing hip replacements on sickle cell disease since I started there 2002. There was a bit before I arrived, but not much. We've done over 100 patients now. We've written up our experience in the well-known journal Hip International. It's I think the impact factors, whether it's below 0.1 or 0.01, I haven't looked up recently. These are these are looking at our patients up to about 2011. So we've got at least a 2-year follow-up on all of these, and it's 2015. So we need to update this, add another 5 years of data to this. But if you look at the results of hip replacements in sickle cell disease, I'm sort of most interested really in this revision. Revision is the key thing. Do they need another operation? Because you don't want patients to have another operation. And I'm pleased to say that really we've only had one reoperation in that first cohort. And that was for a very complex case of instability. A lady had been in bed for 7 years in Nigeria. It's a long story. But what I'm particularly pleased is aseptic failure at 0. And the study above is a very large series from Saudi Arabia, longer follow-up. So they've got a revision rate of 6%, and that's because they're using metal on poly bearings. So as that series progresses, they're going to have more revisions, and ours is going to stay static because we're using ceramic on ceramic. So in general terms, if you're going to do hip replacements, it's a really good thing to do, really gets people back to normal. Raise the prospect of hip replacement early with the patient so they can organise their lives and get their heads around it really. Multidisciplinary team, and complications are really infrequent. So I hope I've sold that message. Hip replacement for collapse disease if the patient wants a hip replacement. Yeah, that's all pretty straightforward, isn't it? Now, this is a sort of a minefield, really, and I'm deliberately going to hopefully deliberately run out of time so I don't have to talk about it for very long. Oh, no. John's telling me I've got 10 minutes. there's all sorts of things you can do for an uncollapsed femoral head. And I mean, it's potentially hugely exciting, this area. You know, if you can give someone a pill for avascular necrosis and stops the whole thing happening, then that's surely great, isn't it? And I'm delighted to say that there's lots and lots of these agents being studied. You know, everything from statins to bisphosphonates. There's all sorts of stuff going on. And, you know, in Britain, we've got a couple of trials looking at bisphosphonates and avascular necrosis about to start. So there's all sorts of stuff going on. Unfortunately, none of them seem to obviously work at this point. But again, it's work in progress. I think the surgical treatment of it is core decompression. And this is a mysterious operation where you drill the femoral head, drill the avascular segment. One of the key things is the avascular segment has to be big enough to actually hit accurately with a drill. But this is sort of paper that I love quoting because it basically says that core decompression is no better in sickle, you know, is no better than physiotherapy in sickle cell disease, which sort of you know, supports my prejudices on this. But there is a place for it. I mean, it's usually in very young patients with very early painful disease. And the trouble is a lot of early disease isn't actually particularly painful. This girl's 18, she's about to go to university. She's actually got a very tiny area of collapse on her right hip, but none on the left. So I did drill them both. I drilled the right because I was going to drill the left. You know, she hasn't had a hip replacement yet, and she's out at 8-9 years now, and it's got her through university, got her a job and all that kind of stuff. But you can see that on the right it's collapsed more, and you know, she will have a hip replacement eventually. But again, I've bought her some time with that. But I think the thing with core decompression that's maybe most exciting is the use of biological adjuncts. And biological adjuncts, there's all sorts of things. There's cell-based therapy and scaffold-based therapy used together. So you sort of give a big biological stimulus to get the bone to heal, and then you support the bone while that biological stimulus is working. And you know, there's a great review actually in JBJS reviews looking at all of that. So you can look at all that in your own time. Next slide, please, which is hopefully the last one, I think. Is it the last one? Can I just move on, guys? Sorry, I'm just dripping it out. Oh, yeah, shoulders. That's right. So, yes, AVN does affect other areas. So shoulders, they're much less prone to collapse because they're not weight-bearing. But obviously, we do treat those with shoulder replacements. Next slide, please. Just press the thing. Thanks. And that's MRI pictures. And again, next slide, please. A couple of shoulder replacements there. And again, so you can have one shoulder replacement, then you can have another shoulder replacement. And then actually you may end up having both your hips done. So the whole thing sort of is, you know, just all a bit depressing, really. But that certainly is the kind of thing that can happen. There we go. And the hips are going to turn up. So this poor lady's she's got the whole set, really. But shoulder's not quite as good. The shoulder doesn't quite feel normal. Well, ankle, knee, and spine. The knee can be affected, but because the joint actually isn't usually involved, it's usually the bit of bone just underneath the joint called the metaphysis. So even though the scans look really scary, often surgery isn't required, just pain management. Ankle, I mean, that's the one ankle operation I could find in the sickle patient I've treated. It's extremely unusual avascular necrosis of the talus. Now, as our sickle patients are getting older, they're also becoming victims of orthopedic conditions that other older people get. And the scourge of middle-aged women is trochanteric pain or greater trochanteric pain syndrome or trochanteric bursitis. So this is typically a middle-aged sickle patient with pain over the outer aspect of their hip. They can't lie on that side. Pain radiates around to the buttock. And it isn't avascular necrosis, you know, basically is what I'm saying. You get an MRI scan to exclude avascular necrosis, but actually what you're looking for is some increased signal over the trochanter. So we tend to inject these once with steroid, and then if the symptoms recur, actually what's really quite promising is shockwave treatment. This is actually a genuine use of shockwave treatment. It's very good in tendon conditions in orthopedics. We're very excited about this, particularly as we don't have to administer it ourselves, which is also excellent. So in summary then, you know, avascular necrosis is very common in sickle cell disease, as I'm sure we're all aware. I think when the hip is really where the orthopedic surgeon is the most useful. So if you want to get an orthopedic surgeon interested in sickle cell disease, find the hip surgeon really, because the other guys aren't really very useful. Shoulder surgeons, useless, you know, you just don't need them. So you need a hip surgeon because they're going to be able to deal with most of your problems. And also we tend to be nice, well-balanced, sensitive guys as well. Your treatment of avascular necrosis depends on SCD. Yes, which I can't remember now what it means, but no, on the symptom severity, the presence or absence of collapse, and the degree of involvement of the femoral head. If you've got collapse disease, you either take painkillers or do a hip replacement. Treatments for non-collapse disease are highly variable and unpredictable, and the key thing is you mustn't do them if they're really not going to work. Hip replacements are safe and predictable in sickle cell disease, and please remember other causes of hip pain, particularly in your older patients. Thanks very much indeed.
Maybe one question.
Yeah, good. Only one, yes. Is that Fenella lurking at the back? Oh dear, you're the person I least wanted to ask me a question. With your incisive mind and clear sort of identification of waffle.
Several schools, you can put them in standing frames to try and prevent these problems. Do you think people with sickle cell disease should, like the rest of us, to avoid our venous problems from our legs coming up into our brain? Should we also stand to avoid hip problems?
That's a good point. I mean, I think you need to be active to avoid hip problems. I think that the era of just telling kids not to play sport and stuff, I think that's long gone. I think we're a bit more realistic about the factors we can and can't control. That's what I would say to that. So any kid with sickle cell disease, I mean, avascular necrosis in children is a whole different game. It's slightly less bleak in some ways, but you can't just wrap these kids up in cotton wool. So I'd always get people out and about.
And just to emphasise from a patient perspective, my husband had his hip done last year and it has been transformative.
Good.
So even though I'm interested in neuropathic pain, if you take the hip, if you take the pain away, your husband is better.
Excellent. I'm delighted to hear that.
All right, thank you, Marcus. So next we're going to hear about urology and sickle cell disease with Belinda Morrison here from UE. So Belinda, thank you.
Good afternoon, everyone. Thank you for involving a urologist on the program today. And I really want to spend the next few minutes just sharing with you some of my experiences that I've gained from seeing patients at the sickle cell unit. I think maybe over 10 years of being there and seeing patients and starting establishing a clinic in about 2011. And just some of the differences that I see from my general urology practice. So I'm going to discuss the common urological conditions that we see in the general population and compare these to these conditions that we see in men or patients with sickle cell disease, and also some future considerations. So what do we see generally as urologists? We see a lot of BPH, we see a lot of prostate cancer, particularly in Jamaica. So in any general urology clinic, maybe about 80% of our patients are either having BPH, symptomatic BPH, or prostate cancer. We also see a lot of urinary tract stones, urinary tract infections. Erectile dysfunction is something we're seeing much and much more commonly these days as men are more bold in telling us about the issues that they're having, and we perhaps ask a little bit more. And then because hypogonadism, which is such a common condition that is publicized so much, men will come in, complain or wanting to be evaluated for low testosterone. Infertility is seen, so is urinary incontinence, urethral stricture disease, and other malignancies. But it's a little bit different in patients with sickle cell disease. And perhaps as we talk this afternoon, we'll think about why there are these differences in the presentations. Priapism is a probably leading urological complication of sickle cell disease, and it really hasn't changed for many years. Hypogonadism we're seeing more and more commonly, as well as what is increasing in prevalence, I would say, are symptoms of bladder dysfunction. And I mentioned these others here as we go along. So much has changed as it relates to sickle cell disease and urology. The life expectancy of our patients are getting longer, so we anticipate that perhaps they will now get diseases that we'll see in other patients who live much longer. The quality of life is improving, so they're thinking about other things. They're not just concerned about their pain, but they're thinking about improved erections, they're thinking about families. And then they will present for questions related to these things. And of course, there's research that is increasingly geared towards managing some of these complications, increased clinical observations. But a lot has not changed. And perhaps if I looked back on a presentation I did maybe 2 or so years ago at a Caribbean meeting, we still have not done a lot in terms of looking at many of these complications. There are challenges in terms of obtaining funding for research in some of these specific areas. It's just not as interesting to people. And because of this, there are just a lot of poor quality studies to look at many of these urological complications. So let's talk a little bit about priapism. And I think all of us in this room know that it's very commonly seen in patients with sickle cell disease. In our population, maybe about 50% of men will have priapism, either major priapism, which lasts longer than 4 hours, or stuttering priapism, which lasts usually 2 or 3 hours. There are many problems that occur in a man with priapism. First of all, it's painful, and pain in the penis is never a good thing for a man. It's biased. Well, I think the men will agree with me, correct, men? No, right. Okay. So it's biased towards younger men. So most data will tell us that most persons who get priapism, the peak age of onset is between 13 and 18 years. So you're talking about a very vulnerable group of adolescents here. It's recurrent. It's not just one complication that occurs and it never occurs again, or maybe 2 or 3 years later. We have men who come to the emergency room every single night because they have major priapism episodes. So this is a problem. There are obvious psychological effects. Who wants to have pain every night in their penis? No one. It's embarrassing. And one of the reasons some of them do not present early, because even for the younger guys, they don't want to wake up their mothers in the morning to tell them their penis is hurting. It's conspicuous in some cases. So if you've seen men who've had recurrent priapism episodes, the penis looks different. Agreed? It's huge, but not huge in a good way, women. It's huge with a big, long shaft and very small glands. So it's disproportionately enlarged, because remember, the priapism is typically affecting the corpora cavernosa, not the spongiosum. So the glands tends to look normal, but the corpora is very large. And I've seen sometimes these guys come into the emergency room, and an emergency room officer who doesn't understand their pathology is looking at them wondering, what's happening here? So you can imagine for this man in a social setting how he feels with this conspicuously large penis. The consequence, obviously, is bothering. It's erectile dysfunction. And we see a large crop of men who are in their teens, late teens, or early 20s, who have erectile dysfunction as a result of this complication. And unfortunately, education, or the reception of the education, is not very good. We know that at the sickle cell unit, all mothers and all boys who pass through the unit are told about priapism, but in practice, when you talk to them, maybe only about a third or so even know that the condition exists. So there's a problem there. And still to this day, management tends to be largely reactive. So a lot has changed in terms of what we think causes priapism. It's more than just thinking that these sickled abnormal cells block the vessels and there's downstream reduced flow and hypoxia. It's a lot more than that. Because if you look at even persons who do not have a large volume of sickle cells, they still can have priapism. So it's more of a molecular dysfunction. And I think the leading prevailing theory came out of Hopkins with Professor Burnett. And just speaking about the dysfunction of the nitric oxide cyclic GMP pathway, and the result really is because of a constitutive reduction in nitric oxide levels that we know already exist in sickle cell disease. So if nitric oxide is what mediates normal erections, nitric oxide causes it results in stimulation of cyclic, increase in cyclic GMP, which results in smooth muscle relaxation. Blood gushes into the artery gets nice and tense, it compresses those draining veins, and so the penis remains hard. The man enjoys intercourse, and then at the end of all of that, phosphodiesterase breaks down the effect of cyclic GMP, and that's a normal cycle. However, patients who have sickle cell disease generally have lower levels of nitric oxide. As a result of those lower levels of nitric oxide, they have lower levels of cyclic GMP and constitutively lower levels of phosphodiesterase. So what happens to them at 1, 2 o'clock in the morning, which should happen to most normal men? What happens at 1, 2 o'clock in the morning, men? Come on, wake up. Not sure? I'll tell you what happens, or what should happen. You should be having REM sleep, and you should be going through these normal nocturnal erections, which are normal and physiological. So that's when you have all of those erections in the night, maybe 6 or 7 of them. And you may not know unless you get up and you want to pee and you notice, wait, my penis is erect. So this is normal, it's physiological. And under those circumstances, it appears that the patient with sickle cell disease is now being exposed to much higher levels of nitric oxide than they are used to. But they don't have enough phosphodiesterase to break it down. And so there's an imbalance. But there are other mediators that have been implicated in research over the past few years. Talking about things like increased levels of opioorphins, increased levels of adenosine, reduction in the Rho kinase pathway, which we know results in vasoconstriction, and even things like perhaps reduced testosterone. Why reduced testosterone? If we think about it, we treat a lot of patients for prostate cancer by either removing the testes or blocking testosterone in some way. And the observation is that these patients have reduced nitric oxide levels, reduced cyclic GMP, and reduced phosphodiesterase. The same situation in the patients with sickle cell disease. When we increase testosterone levels, this is reversed. So perhaps there may be an association between reduced testosterone levels in these patients and priapism. So there are lots of prevailing theories, but the question is how much of this is being translated into actual management in these patients. The large part of our management is in the emergency room. They come in the night, they have major episodes lasting longer than 4 hours, and we act very quickly. And we tell our patients from very early to make sure that they present to the emergency room as soon as possible. Don't wait until the 4 hours, because if you wait until 4 hours to leave your home, it probably take another, an hour or so, depending on where they live, to get to the emergency room, then to be assessed by the physician. And this is a critical period, because it's a compartment syndrome. We should not ever tell patients that systemic treatment is enough. It's not enough. If it even goes away, it went away on its own, it would have gone away on its own. But it should not be the only treatment. And still we have patients going to peripheral hospitals just getting IV and analgesics. They should be referred, and they should have aspiration done. Now, the aspiration can be done. Usually we aspirate at the same time as giving them phenylephrine. Obviously, they have to be monitored, and you have to give them about 100 to 500 mics per mil. You can give them every 3 to 5 minutes up until an hour until you would figure out whether or not it's going to work. My experience is that the later the patient presents, the less likely the phenylephrine works. There's not enough functional smooth muscle there for it to work on anyway. And so you have to subject them now to distal shunts, which can be done under local anesthetic. We can use a true core biopsy needle or even a Branula, which is a winter shunt, and that's placed through the glands. Or you can use a blade, a scalpel, through the glands, which is called an Ebbinghaus shunt. Or you can, under anesthesia, you can excise the tip of the corpora cavernosa, and that's called an algorab shunt. And if these fail, traditionally it used to be thought that you progress to proximal shunts, but these are much more involved, have more complications. And in that era where we now have penile implants, most people would say if the duration of the priapism is long and the likelihood of ED is very high, or these shunts fail, why not just put an implant in? We wish we had that option here in Jamaica. I want you to just look at the bottom part of this chart, and this is coming from the AUA guidelines, just to see how very poorly populated the management of priapism less than 4 hours is, the so-called stuttering priapism. And that's where we're lacking, and that's where perhaps we can all talk about what are some of the things that we can do to look at to improve on the management of patients from this perspective. So it's not a problem for us as urologists to aspirate a patient's penis. We do it all the time. But we don't want to go there, and we don't want to have to do this every night or too frequently. So it's not one size fits all. I'll have patients with stuttering priapism. Some will respond to oral therapy with pseudoephedrine. Some will not respond to that. Some you try all different sorts of things. It will never work. So it really depends on the individual and the severity and the frequency of their episodes. Is there a protocol? Not much. there's not really a protocol for the management of the patients with stuttering priapism. The quality of evidence, we will speak about in a little while, is not very strong. And how affordable are these options for the patients? The adverse effects we have to think about, and what's the association of all of these symptoms with low T. So the adrenergic effectors are your oral agents. We typically use in Jamaica oral pseudoephedrine. And I find it works very well for patients with infrequent episodes. Infrequent meaning maybe less than 2 episodes per week, and maybe lasting for less than a half an hour, an hour. However, in the probably only randomized study that has looked at this using oral epinephrine and ephedrine, there is no significant difference. And there were issues, I suppose, in terms of the sample size for this study, but the long and short of it, that's the highest level of evidence that existed, and instead it did not work. And of course, they chose patients with different severities of their priapism. I speak about the nitronergic effectors as agents like phosphodiesterase inhibitors. Again, this suggestion came out of Hopkins with Arthur Burnett. Seemed to be effective when they looked at initial case series 4 or 7 patients, and it really, daily use of sildenafil or tadalafil in the morning seemed to reduce the frequency and the duration of the priapism episodes. However, when they actually studied, they weren't able to accrue more than 13 patients over a 2-year period, and there was no significant difference seen. Now, having spoken to Professor Burnett, he's well aware that the sample size was too low, and it was really hard in Hopkins to recruit as many patients as they could. But the bigger part is, even on our end, when we do prescribe these drugs, how many of our patients really take them? So we had a presentation with Pfizer on Wednesday in our academic session, and I asked her, what's the cost of Viagra currently? And she said $2,800, Jamaican dollars. So let's calculate that. Who can do math very quickly? I don't know. That's about per tablet. Yeah, that's per tablet. So that is what? Here, this math brain. It's 2,800 Jamaican per tablet. So it's more than $20 per tablet. And this should be taken daily. So clearly, our patients can't afford that. All right? And even with the generics available, it's still out of the reach. I think the cheapest generic sildenafil is about $500 per tablet. So here we've run into a problem. And even for patients who have very bad episodes, I've used it. It does, as much as I've tried to get samples for them, it just doesn't work in very, very severe cases. Then there are the hormonal agents, which probably have been around for a very long time, use of estrogens, and now the newer agents that we use to treat prostate cancer. But why should I be giving a teenager or a young man estrogens or hormonal agents in his early years, when he's developing, when he wants to go through puberty, when his growth plates haven't even fused as yet, right? So we're talking about all these side effects of hormonal agents. And guess what? Even in really bad cases, it may not work. And there are many side effects of hormonal agents. We looked at testosterone replacement therapy, and I'll speak about that in a little while. And then, of course, good old hydroxyurea. Hydroxyurea, which you use so often for so many other complications of sickle cell disease, why not use it in priapism? Nobody seems very interested in looking at it, but it may have some benefit. There's been 1 or 2 case reports are showing that hydroxyurea may be able to abrogate the episodes of priapism and even to reverse the scarring that will occur because of its effect on endothelium. So it's something to look at and study in a much more fulsome way. So future agents could be nitric oxide donors, could be Trentol, even pentoxifylline has been looked at, and adenosine deaminase, just because increased adenosine is associated with priapism. And of course, our agents have to be cost-effective for our patients. So this is the last guideline that was put out for urology on priapism 9 years ago. And this looks at stuttering priapism. And still here, what they have on the guideline statement, that 16, is talking about using LHRH analogs in these patients. So I can tell you, as a urologist, many of us are trying to minimize our use of LHRH analogs, even in patients with prostate cancer, because it increases cardiovascular morbidity. To suggest that for use in these very young men is probably not the wisest thing to do. All right, so this is what we end up having to do, penile implants. But again, it's cost prohibitive. In centers where they have the resources, once they come in and have a very long, painful major episode, they may give them a penile implant. To organize a penile implant in Jamaica requires funding and requires a lot of resources for the patients, so it's not just as easy. An implant right now in Jamaica at our local cost, just cost of the implant alone is about $12,500 US. And these things are not covered by insurance. So let's talk a little bit about hypogonadism. It's very topical. All the men want to know what their testosterone levels are and if they can get testosterone shots. And that's in the general population. I don't find as many men with sickle cell disease coming asking to have their testosterone evaluated, but as part of my protocol for evaluating anyone with priapism, I tend to do an early morning testosterone. And sometimes we get referred patients who have ED that's not related to their priapism, previous priapism. We'll do the T levels. Or in pubertal males who are having delayed puberty, we check and see what their T levels are. I mean, nobody really knows why it happens. It could be related to multiple microinfarcts in the testes, or it is thought that oxidative stress, which is responsible for so much now, priapism included, may be responsible for these testosterone, these hypogonadism in these patients. We thought that we wanted to look at the association between testosterone deficiency and priapism episodes, but we knew that our sample size was small, so it's about 50 patients. We did not find an association, but we think perhaps with a much larger sample size, we could find an association that low T levels were associated with priapism. And here we had a cohort of 7 men who had sickle cell disease. All had hypogonadism, and they were symptomatic. 4 of these men had regular episodes of priapism, and we treated them, and the main purpose was to treat their hypogonadism and their symptoms. So we gave them testosterone replacement therapy. It did increase their testosterone levels, it relieved their symptoms of hypogonadism, and surprisingly, it also improved their priapism episodes. However, the challenge of introducing testosterone replacement therapy for treatment of priapism in these patients, and this is stuttering priapism I'm referring to, is that number one, testosterone replacement therapy is a very good birth control for men, right? It cuts off the whole axis. So if these men are interested in having children, that's probably not the route to go. In young men who have hypogonadism in general, sometimes we suggest a drug like clomiphene. And the question is, would this be safe in men with sickle cell disease? I don't know that we really know the answer. How long do we treat these men for? And what is our T cutoff for these men? In general, we're using these large ranges that are coming from based on large sample, normal population, especially in the older men. Do we use these same ranges for our younger guys? And how often are these patients actually symptomatic? So I'll run quickly into bladder dysfunction. I think everybody knows that patients with sickle cell disease are higher prevalence of enuresis, obviously in childhood, but not much was known about what happened to them as they got older. So I noticed that with my time in the clinic, I would see a lot of these older persons complaining of increased frequency and urgency and even sometimes incontinence. And so when we had 400 patients, 200 with sickle cell, 200 without sickle cell, and what we found was that a significant number of these patients who as children reported enuresis continued to have enuresis in adulthood, and a large population of them had overactive bladder symptoms, almost 40%. We shared the information with our colleagues at Hopkins, and they were able to look at a sickle cell mouse model, and they found that there was some nitric oxide dysfunction, the same nitric oxide dysfunction that you get in priapism in these sickle cell mice was present in the bladders of these patients. So perhaps this has some unifying pathophysiological mechanism in the whole presentation of these patients. Finally, infertility. I have found personally that male reproduction is not a priority in patients with sickle cell disease. Nobody encourages it, nobody talks a lot about it, and maybe sometimes the patients are too worried about everything else to talk about it. But if they're living longer and their quality of life is improving, why not? Infertility is common in these patients. Well, obviously, if you can't get an erection, you can't have a child, correct? Well, normally. If they have hypogonadism, the same thing. They won't be able to have children. If they have testicular infarction, the same thing. And then perhaps oxidative stress is responsible in these patients. But then sometimes we are responsible. Have we thought about how many patients we start on hydroxyurea? Do we really counsel them about the fact that it can alter spermatogenesis? And is it reversed after we start the drug? I don't know. In these patients who have undergone stem cell transplantation, is it reversed after? But it's certainly a risk. Not much has been studied recently on infertility in sickle cell disease and why. There's no one interested. The last publication was in 1988. And again, it just said in a very small cross-sectional study, these men were more likely to have low sperm count, impaired motility, and everything else. But if oxidative stress is a central theme to so many of these presentations in these patients, perhaps just like in the general population, it may be responsible for the presentation of infertility in these males. So I think it's a ripe area for research. Other things we see, essential unilateral hematuria, so they come in with bleeding and bleeding. We do all kinds of scans, they're normal. Perhaps it's papillary necrosis. A lot of times, thankfully, it resolves with fluid hydration, but sometimes we have to put a scope up, look, and just by just the pressure of the jet, it just stops the bleeding, or we can cauterize an area. Thankfully, we don't see this one at the top anymore. Well, not much. Renal medullary cancer, because it's uniformly fatal. While Professor Hanchard, our pathologist, was alive, we looked at, I think it was 12 years of men with renal cell cancer, well, renal cancers at the University of the West Indies. And maybe only over that time period, only 2 patients were found to have renal medullary carcinoma, one of which was a medical student. So we are thankful that despite how prevalent sickle trait is in our population, we do not see a lot of renal medullary carcinoma. And so I know my time is up, so I'm just going to speak about things that I would like to see for the future as it results to urology and sickle cell disease. We must do more high-impact research in this area. I think there are many areas where there is great interest, and we can look into these areas. I think we should consider the differences in the ranges of diseases that we see in these patients as opposed to other patients. We don't see much patients with sickle cell disease complaining about BPH and prostate cancer and stones. Is it that it's protective, or is it that they don't present with the symptoms? These are some of the things we have to think about. And there clearly has to be greater conversion from bench to bedside, particularly in patients with priapism. We're doing a lot of basic science studies, but we're not seeing it transferring into medications that are applicable for use in these patients. And obviously, I'm here just to talk about the potential for collaboration. So thank you. I'm sorry for going over time. Thank you.
Thank you so much. I think in the interest of time, we should keep moving. Yeah. Thank you.
Good afternoon. After a psychologist, orthopedic surgeon, urologist, you have a family doc. Yes, Wile. And I've changed my topic a little bit from pregnancy in sickle cell disease to reproductive issues in sickle cell disease. I don't know which button is what. My team is ignoring me. Okay, so we'll start with female issues in sickle cell disease, other than just pregnancy. And just a couple quick slides to remind us all that young girls will have issues with delayed puberty, as do young boys. And it's something really, really important to talk to them about, because they're in class, they're not getting boobs, they're not getting periods, which nobody knows, but they know, and the girls are talking about it. We all hate them, but we want to see them. So, but I tell every one of my young girls when the pediatricians give me a chance to see them, that I don't have any sickle cell adult by age women who don't have boobs. So don't worry about it, you're going to get it. But there is a delay, especially in the SS patients, and other aspects of menstruation is that there are some reports, because there's not much work, looking at these kind of issues in people with sickle cell disease, that menses may be more irregular, heavy, and may be associated with dysmenorrhea, which can be a critical cycle where those with dysmenorrhea are going to be more likely to experience VOCs just before and during and after menses. A lot of our girls have to be educated to look out for possibility of painful crisis with the onset of menses. There was this issue, and when I do these talks all through different regions in the island or elsewhere, I want to talk about this because up to now, a lot of families and girls with sickle cell disease and families of girls with sickle cell disease feel they won't get pregnant, so it's okay. Because we've had in our mindset, and there were in fact earlier reports that maybe there is infertility in the sickle girl, that girls with sickle cell disease are subfertile or infertile. That is not the case, and our newer literature supports that. That's not the case. Pregnancy, the first pregnancy may be a little bit delayed and has been shown to be a little delayed, and Prof. Sargent, Prof. Thame have done a lot of work in this area, but it may be delayed for various reasons. We said menarche is delayed, yeah, and coitarchy may be delayed. Their socialization is a little bit different, but there is really been no difference in time from coitarchy to first pregnancy. Last slide on reproductive issues, contraception. I would like to think that this is lessening all the time, but up to now, we will still have girls come to the clinic who are told that when they go to healthcare facilities, there's hesitation in offering them contraceptives. And rightly, we can imagine we have thromboembolic disease, and OCPs are going to cause thromboembolism, and what do other hormonal contraceptives do? And so I don't really want to deal with giving you contraceptives. But the risk of getting pregnant can be so much severe compared to any theoretical risks of contraception that they should be offered. Also noteworthy on this slide is that more recent studies still highlighting that there is low interest of sickle cell adolescents in seeking contraceptive counseling, and contraceptive utilization is low as well. So even in our national surveys, the sickle cell girls and boys are using less contraception than non-sickle teenagers. So despite popular belief, all common methods are acceptable. The progesterones only are probably the safest ones of the hormonal contraceptives. IUCDs, no evidence of higher percentage of infections. OCPs, the increased risk of thrombosis is conflicting in studies, but at the very least, we just want to ensure that they don't have other cardiovascular risk factors and other thrombogenic risk factors, and we should be able to use. A lot of the studies are kind of observational from older times, and now in the recent years, we've had much lower dose estrogen combined therapies, and they are probably quite useful. So we encourage our girls, and I start talking to them from the time they are 13, 14, and the day the pediatrician is not available, and they might end up with an adult doc, and the families are probably very dismayed. Why is this doctor talking to my young girl about contraception and sexual activity? But teenage pregnancy is a real issue in Jamaica. So these are the guidelines. You can see they're a little bit old, so definitely overlooked because, and I've been very tired because we're doing just a lot of work, but I can't find anything on pregnancy guidelines in the NHLBI guidelines. So to manage pregnancies, but the guidelines from the WHO and the ACOG guidelines state that there is benefit of progesterone only, low-dose COCs, and all other methods outweigh the risk associated with pregnancy. Better design studies are needed. Male issues. Belinda, I never ignore it. I knew you were going before me, so I don't need to spend any time at all on this slide, but these are important issues. I'm not going to say it because Belinda has said it all much nicer way than me. So this is a real topic that you're here to listen to. The placenta, as you can imagine, any other vascular bed in the body, the placenta is also has many issues when it is seen in a sickle woman. This can be abnormal in size, location, adherence, and histology. There is decreased placental weight. Studies show increased vascular resistance in the uterine artery, suggesting impedance to flow. And the histopathology is also abnormal. Histopathology is very, very similar. Catherine Hassel has done a wonderful, I read that article all the time. At the review you did a few years ago on this. So a number of these abnormalities are implicated in the multiple issues that we see in a sickle pregnancy. There is increased cardiac output, as is seen in pregnancies on a whole, but the physiological stresses of pregnancy in a sickle woman may reveal previously asymptomatic chronic cardiopulmonary dysfunction as well. So we need to look out for that. This is just a composite of looking at sickle cell disease and pregnancy outcomes. And of course, we always speak about maternal but also fetal complications. And a couple of the more recent reviews are what I've highlighted the numbers with, because really and truly studies they have all kind of different reports coming from same parts of the world, different parts of the world. Some studies will talk to very low maternal mortalities, and yet reviews will come and there is high maternal mortality. So you can see, 11 seems to be the number, and this is not our data from Jamaica, which is exactly the same number as well. But increased frequency of sickling in the pregnancy, there's pain, and there's prepartum and postpartum painful crisis, UTIs, pulmonary complications, severe anemias, preeclampsia, eclampsia a little less, but maternal death. Fetal complications, premature delivery with its associated risks of small for gestational age babies, higher risk for C-sections, IUGR, and you can see all the ORs there, low birth weight, fetal distress during labor, and a higher rate of perinatal mortality. Up to these more recent reviews, we are still seeing consistent ORs of 2 to 3. Anemia may be especially worse. So we know there's a physiological anemia of pregnancy, but in sickle cell disease, there can be falls worsening at later gestational ages, especially in SS disease. There may be iron deficiency, so we need to look out for that. We can't just blindly say, oh, people with sickle cell disease are not given iron. Folate requirements increase, and look out for acute hepatic splenic sequestrations. These women are pregnant. I've seen, Susie is right here, and I can never forget that day because that day is very meaningful. We were in ICU with a SC woman who was near delivery, but went into all kind of complications and eventually died. And she had a huge liver and spleen which had not yet been noted. Susie, you remember that? Infections and inflammations, all as a cause of acute severe anemia in pregnancy. Bone pains can increase, especially in the 3rd trimester and the immediate postpartum period. And Prof. Sargent's work, this is a lovely piece of work that I like, where he has shown that there may be a rise in the HbF levels in the 1st trimester, but there is a steady decline from the 3rd trimester, and pre-pregnancy values may not be reached till almost a year postpartum. So you all sickle cell docs can equate that. Acute test syndrome, definitely a problem. Early reviews state up to 33% acute test syndrome prevalence in pregnancy. Later estimates are lower. From our cohort study, 20% in SS, 9% in SC. So look out for that. Preeclampsia, again, conflicting results from different data sets. In the cooperative study, 14% preeclampsia, 1% eclampsia. But in our cohort, really, this is a couple of years ago, there was really no difference between SS and AA pregnancies. Perinatal mortality was reported to be as high as almost 50% in early reports, but it is declining, but still significant, as we said in an earlier slide. Maternal mortality, because this is what is the most painful. Not that the others are not important, but this is really painful. You see beautiful young women living well, want to get pregnant, and I'm not going to stop them. A lot of my obstetrics friends, really, we have real debates, not the kind that you're going to see later today, but we have real debates. Stop telling your women, tell your women not to get pregnant, and that's a big debate. But when they die, then it's really heart-wrenching, many times leaving young babies behind, and many times babies die and mothers die, and it's really just sad. Maternal mortality still exists within sickle cell disease, and I'm going to show you just a couple of slides on our own work in Jamaica. There's a lot of work that occurs, and there's really very comprehensive and detailed assessment of maternal death. The surveillance in Jamaica is huge, and what this slide shows is, this figure shows that maternal deaths are declining in Jamaica, but the indirect deaths, which are deaths due to other diseases, not a direct result of pregnancy, but women with HIV getting pregnant, women with cardiac diseases getting pregnant, and women with sickle cell disease getting pregnant, indirect deaths are rising. This data stops at 2006, but more recent data continues this incline, and sickle cell disease is a consistent contributor to these indirect deaths in Jamaica. This paper is more recent, which also shows that maternal and what we are calling here pregnancy-related deaths, which is late indirect deaths, have been increasing even over this 18-year time period. Cardiovascular deaths are the main stay, but mortality from sickle cell disease is the next ranked non-communicable disease that's causing these indirect deaths. This was a look we did at all maternal deaths in Jamaica from 1998 to 2007. We are just getting ready to do the next 10 years, where there were a total of 418 maternal deaths in the island, and 10% of them were in women with sickle cell disease. 1% of the antenatal visits during this time period were in women with sickle cell disease. Age was the same, gravidity was the same, parity was a little less in women, so there were a few more unsuccessful pregnancies in these women. This was really great work, and you can, that's kudos to our reproductive health care in Jamaica, that women with sickle cell disease in that time period were having more antenatal visits. They were getting more antenatal care at a high-risk facility, and they were living more in parishes where tertiary care is available. But yet, it was high, and 41% of the deaths in women with sickle cell disease were due directly to complications of their sickle cell disease. So how do we manage their pregnancies? Ideally, and this we hardly get a chance to do this, that's why I start at 13 or 14, ideally, we should be talking to them about it before they get pregnant, and topics for discussion peculiar to sickle cell disease talk about the maternal risks, talk about the risk to the patient, to the fetus, talk about partner testing. A lot of our women refuse this. They are afraid to ask their men to get tested, and I start from right there, or when women talk to me about, I want to get pregnant, doc, what do you think? And that's happening more and more, so that's really great to know, They want to ask you, what do you think about that? But from that time, you talk to them about the low threshold for seeking medical care. In Jamaica, we say, let me just watch it for another couple of days, So we tell our patients with sickle cell, there's no sitting at home and watching anything. Problem, get to a doctor. In pre-pregnancy care, also ensure that you have some baselines, their labs, their liver function, their renal functions, screen for end organ damage. It would be ideal if they had some baseline echoes, their urinalysis, and overload in those patients. This doesn't happen in Jamaica, who are on multiple transfusions, red cell antibodies to minor antigens. If possible, we can't do this much in Jamaica. Give nutritional advice, start supplementation, ensure they are appropriately vaccinated, right? If nowhere else to catch them here, stop hydroxyurea still 3 months before they get pregnant, at least stop ACE inhibitors, ARBs, if they're going to get pregnant, if they're wishing or get pregnant, which is usually when we catch them. Antenatal care, and this is extremely important. A multidisciplinary team is needed, high-risk obstetricians, and their sickle cell docs, whether they be hematologists or internists or family docs. Avoid education. Teach them how to avoid precipitants for crisis. Remember, they're going to be vomiting, or they may be vomiting a lot. Talk to them about these simple things. Seriously, it just becomes a little bit of a disconnect for doctors. So you can imagine for patients, they just don't put two and two together, sometimes. And go through everything again. Look at their medications. At every visit, check their blood pressure, check their weight, check their urinalysis and MSUs every month, a CBC retics every month at least in early pregnancy. Obstetric ultrasounds, if available, 7 to 9 weeks for viability scans. And many of these guidelines, we use them ourselves, and many of them are detailed in the green paper, the Royal College guidelines, because as I said, the NHLBI doesn't have any guidelines in their recent thing. Non-stress testing and biophysical profile testing weekly after 32, 34 weeks. Doppler, where possible. I like to leave this in, even though there's not much evidence for this, but what we're seeing postpartum, the problems, I think that's important to do early and bring in a cardiologist if possible, if we're seeing problems from their baseline. Education counseling at each visit. Do not plan for deliver no later than 38 to 40 weeks, because placental insufficiency is just going on. I'm going to leave this because it's just too much to do. Transfusions, we had a long talk with Ross and Prof yesterday, so I don't need to do any of this except to say that routine prophylactic transfusions, I think we can safely say, are not indicated. But none of us are going to argue the fact that be very quick, and I keep thinking how we can encourage our women to have match donors available so that the minute they get in trouble, that's when they need the blood immediately. But definitely there are going to be cases where they might need some prophylactic transfusions, okay? But we did this a lot yesterday. Intrapartum care, be careful again. Monitor the fetus closely. Proceed to term unless there are other indications. C-section, there's no, sickle cell disease is not an indication for doing a C-section delivery by itself. Hospital delivery is strongly encouraged. I encourage my women, no underwater and at home and all those kind of exciting things. Please get to the hospital. Avoid overhydration. Oxygen, have cross-match blood available, yes. Postpartum neonatal screening, right? Early ambulation, 1 week postnatal visit, 6 week postnatal visit, monitor up to 1 year, contraceptive advice right away. So what is the most important thing that we talk about to the patients and to doctors, our primary care doctors, nurses, and healthcare professionals is, unlike other complicated pregnancies when most problems are going to stop the minute the pregnancy finishes, in sickle cell disease that does not happen. We have had women, unfortunately, I can't forget a couple of them, normal pregnancy, normal delivery, go home a week after, problems, and we have had deaths. So it's really painful. So women, families need to know this, healthcare professionals need to know this, that, for a sickle woman with a pregnancy, problems don't stop when her pregnancy is concluded, okay? And so contraceptive advice for future references. So this is the last slide, John. Sickle pregnancy is a high-risk pregnancy. That's it. Jamaica has done extremely well because we now have not just a high-risk clinics, and they are almost all across the island. We now have high-risk clinics, which is where cardiac and sickle cell women are managed once they get pregnant. But and this is a lovely paper. Sickle pregnancy can be successfully managed with a prompt and aggressive multidisciplinary approach. This paper comes out of Accra, Ghana, where they have declared quite nicely that joint obstetrician hematology, or SCD expert outpatient and acute inpatient reviews with close maternal and fetal surveillance and simple protocols for management of common severe complications such as acute chest syndrome can really make huge difference in outcomes. They had like a 90% risk reduction of maternal death and like a 67% reduction in perinatal mortality with simple, nothing including prophylactic blood transfusions, just to declare. And that's my last slide. Thank you so much. Thank you.